Awesome. We're getting started learning neurology.
Okay, I'm going to share my screen now. Oh, it says host as disabled participant screen sharing.
Let me make you co-host. I don't know how to change that. Can you, is it working for you now?
Yes, it is.
Cool.
Okay, can you guys see my screen?
Yes.
Yes.
Okay, so this is a case I picked up from the PubMed.
Awesome.
A 67-year-old male patient was transferred to our institution with acute onset, progressive and ascending lower extremity weakness and voiding difficulty for 3 days. He also had fever and chills. 20 days prior, he engaged in outdoor activities. 3 days later, he developed flu-like symptoms, including fever, chills, general malaise. He underwent conservative treatment with the over-the-counter medications, during which time he went hiking again. 11 days after the original activity, his symptoms progressed and he visited a local clinic. So these are his symptoms. Next is physical exam.
So let's stop and let's tease out these symptoms. If you want to walk us through, Seema.
Yes, so he's 67 years old with acute progressive onset of progressive and ascending lower extremity weakness and voiding difficulty for 3 days. But it all started from 20 days ago when he initially developed flu-like symptoms with fever, chills, and general malaise. And then he took some over-the-counter medications, went hiking again, and that's when his symptoms progressed. So he visited a local clinic at that point.
So what are we thinking? And, this is up, anyone can chime in. So this, let's say this patient's in the ED, 67-year-old male with acute onset of progressive ascending lower extremity weakness.
Mm-hmm.
And difficulties voiding. So with that history alone, where do we think, this could possibly localize? Because that's always, like a major question in neurology, right? Is this neurological? Yep. He has symptoms that sound neurological.
Yes.
Would it be more peripheral versus central? Or
It could be. Yeah. So somewhere in the somewhere in the nervous system. Usually with peripheral, he has
with peripheral, we would not see a voiding difficulty.
Yeah, exactly.
So that is one. And the second thing is he has a progressive weakness. So that's the indication to say it's neurological, right?
Yeah, progressive onset of, when you think progressive onset of weakness, you usually, typically with like inflammatory issues or, what else could cause weakness? Like generalized infections or
also metastasis.
What do you mean?
So suppose if they have a tumor and if they have mets in the spine, any space occupying, it could also cause lower extremity weakness and voiding difficulty, right? But he has fever and chills here.
Yeah. If he had like a growing tumor on his spine and all of a sudden it reached a critical mass to where now it's like impinging on the spinal nerve, then yeah, it could definitely cause spinal compression, which would be a neurological emergency. Cool. And so now we have fever and chills.
Yeah, so and lower extremity weakness, which is progressing and ascending. So on physical examination, a red-crusted eschar was observed on the patient's neck that had not noted previously. He was hospitalized without delay and doxycycline was administered under suspicion of scrub typhus related to outdoor activities and appearance of eschar. However, his symptoms persisted and after 9 days, acute urinary retention and progressive weakness of both lower legs developed.
So this, he has some kind of infection going on, some kind of scarred, looks infectious, give antibiotics, cool. But he's still having, despite antibiotics treating this skin infection,
Mhm.
his symptoms are progressively still getting worse. That's
Yeah.
how I would
Like-
summarize
like,
that.
would that's just like clue in that like that it's likely not something like bacterial. I guess the hiking thing kind of throws me into the category of like something tick related,
Are
something
you thinking of Lyme's
woody tick.
disease?
Lyme is certainly a thought. You know, some sort of tickish just from the hiking, and like I said, something viral. I'm sensing something viral, considering it being so acute, such an acute onset. Unless so I know like METS was spoken about earlier, but normally something this quick, I would kind of, even with spinal cord syndrome, I don't know if it would present in like an ascending way. But I guess maybe
That's
it could.
true. That's actually a really good point. You're right. Well, if it was a MET, it would just be like an acute, spinal cord lesion. It wouldn't be, that's actually, I think, a good point. It wouldn't present like an ascending migratory. It would just be like, boom, insult, nervous impinge.
Yeah.
We have,
And then
cauda equina or conus medullaris
Right.
syndromes. That's
Mhm.
actually, that's a really good point. Yeah.
but the hiking thing throws me into like some sort of tick, spider, something like that.
Yeah.
And then
Yeah.
with the eschar on the neck, so now we have like a dermatology manifestation, physical manifestation that sort of leans me into sort of that direction.
Yeah.
Yeah, I was gonna say the similar thing, and also, ascending paralysis made me think of, and after following an infection, it's like Guillain-Barré syndrome.
Yeah.
That made me think of that. So
Sure, yeah.
probably this is like an immunological reaction secondary to the infection. That's what I'm thinking.
Yeah. That's a very good thought.
Mm.
Okay, so at the time of admission to our hospital, he had fever, chills, myalgia, dysuria, weakness in both the legs. Physical exam revealed an obvious eschar on the neck. So this is the figure. Can you still see the?
Oh, this is why I didn't go to dermatology. This is gonna be gross.
Okay, here. Can you see the diagram?
Oh, okay, that's not. I'm thinking like flesh-eating bacteria. You're seeing like the muscle and the bone. Okay. We'll take a little bite.
Yeah, it does not
So
look.
is that slightly target-ish? Look at B. Is that slightly like erythema migratum a little bit? Like, I don't know. Like it looks amazing. I don't know. It looks a little target-ish, but I could be wrong.
The target-ish is classic of Lyme's, right? Lyme's is the
Yeah.
target symbol. Yeah.
Yeah, you're right about that.
Does this look
Yeah.
like that? It's more of like, yeah.
I mean, A is saying that A's initial symptoms, I guess the timeline there, but I was, as far as B is concerned, it looks a little, if you see like there's like an outer ring of reddish, then there's like a pale, and then there's like a red center. So
This
I
one.
don't know. I was looking at more like B, but yeah, I don't know.
This one?
I'm Googling it right now. The target lesion for Lyme disease. The bullseye. So it does. Let me see.
I think
got it.
this one is just erythema around the, probably where the tick bit, where the tick, but the targetoid lesion is more like it's different, I think.
So here.
It's the-
this is
yeah,
what
it's like the second line. The third picture is the second line, is the classical.
See?
Yeah, that too. It's the classical targetoid lesion. But this one looked to me just like erythema.
That's what I would. I
Yeah.
agree.
Uh-huh.
Yeah, this is the picture. Oh. So it still had a crust in place. On neurological examination, motor power was decreased in both lower extremities. Grade is 2/5. Sensory testing showed hypoxia to touch on the lateral side of the left lower extremities, including the buttock and the inguinal area. So lateral side of the lower extremities. So it goes this way. So it's L5S1, right? Sensory. Okay.
If you type in spinal cord roots sensor, oh, okay, that pulls it up too. There we
Yeah.
go.
So the side is, yeah, L5S1.
Nice.
That's the lateral side. And Babinski reflexes were 2+ in both lower extremities. So then this is an upper motor neuron lesion.
Yep.
Urine 800 ml was drained by Foley catheter. Oh, severe retention. The results of routine hematologic testing was normal, except for elevated ESR, which is 26, and alanine aminotransferase 59. CSF shows WBC of 18 and elevated concentration of protein, which is 76.4, and a decreased concentration of glucose, which is 43.
So if we go back to his neuro exam, so he has weakness in his lower extremities. He has sensory deficits on the lateral aspect of lower extremities bilaterally. And he also has sensory deficits in the buttocks and inguinal area. So if we go back to that dermatome, so we said, you know, could this be L5, L6, but he also has sensory deficits near the buttocks region. And that's like S5, S4, S3 near the inguinal, that's S2. So let's talk about localization. So where do we think it localizes? Do we think it's peripheral nerve?
I mean, because Babinski
Babinski
reflexes increase, I think it's upper motor lesion.
It's definitely somewhere in the sacral region.
Yeah, exactly. Lumbosacral plexus, and thinking also urinary retention.
Yeah. But for the lumbosacral plexus, those are still lower, those are like roots of nerves. So in order to get that upgoing toe, we would actually have to hit the nuclei of some of these nerves, or at least hit the spinal cord. So I think it would have to be above the plexus, because it includes L5, S1 through S5. You have upgoing toes. So I think it would have to be at least in the spinal cord. And remember this, I've learned this, a lower motor finding could include a cervical pathology. Even though there's no arm involvement yet, know that if someone comes in with lower extremity weakness, you got to look at the lumbar, thoracic, and cervical, because cervical etiologies can cause lower motor symptoms before it hits the upper motor, or before, sorry, it can cause lower extremity weakness before it hits the arms and even the brain. So that's something I learned. I learned along the way in seeing patients. So I would say this probably localizes somewhere in the spinal cord or and above.
Oh, so you're saying it's above spinal cord. Oh, I see. Okay.
Yeah, at least spinal cord and above, because because of the upgoing toes.
Yeah, possible. True, correct.
And also the bilateral nature of it, because if it's peripheral, it would have to affect not only
lateral.
Yes, and it's uncommon to have bilateral lumbar plexus involvement to cause lower extremity weakness. Not saying it can't happen, but especially how acute it happened, it's more so the quickest way to get an acute pathology to cause lower extremity weakness would be somewhere in the spinal cord or above.
Yeah. I'm not sure what to make sense of the elevated ESR and
The elevated ESR, it's mildly elevated. It's not too crazy.
and the aminotransferase right
So
now.
the SED rate's probably elevated, you know, it's an acute inflammatory reaction.
Inflammation, yeah, inflammation.
Yeah, and then the ALT, that's not too crazy. That's, you know,
That's only 59. Yeah, it's not
Yeah.
too elevated also. True.
awesome. And then you talked about the CSF study. So we have white blood cells. Are there supposed to be any blood cells in CSF?
No.
Correct. So if we see
shouldn't be.
blood, so if we see blood cells, red or white, we got to figure out, well, why are they there? Because they're not supposed to be there. So the blood cells are there. Sometimes when we get CSF studies, we get the cell count and differential. So it'll tell us of all these white blood cells, is it neutrophilic predominant? Is it
Or
lymphocytic
lymphocytic, yeah.
predominant versus eosinophilic predominant? So if it's neutrophilic predominant, what's the thing you're supposed to think about on board exams?
Bacterial, like a bacterial pathology.
Yeah. If it's lymphocytic, what are you supposed to think about?
Something viral, or like
Viral, yeah.
TB
Or-
fungal.
Yeah.
fungal.
Right, viral, fungal. And if it's eosinophilic, what do you think about?
Oh, parasites?
Like parasitic.
Ah.
Yeah.
Yeah, parasites or some kind of maybe allergic reaction or something.
Mhm.
So the white blood cell count is elevated. We have protein that's also elevated. That could be, you know, due to the white blood cell count. How I think about protein is that the biggest reason why, you know, the biggest carrier protein in your blood is albumin, and albumin is
Albumin.
huge, so it can't cross the blood-brain barrier, right? So if you have so albumin is supposed to, you know, it's too big, so huge, not really crossing the blood-brain barrier. But if you have protein in your CSF, you think, okay, there's probably a breakdown at the blood-brain barrier, because if you don't have any cells in your CSF, then you really shouldn't have any protein in your CSF.
Right.
That's kind of how I remember it. And you have decreased glucose, so something is either consuming the glucose or taking up the glucose. You know, so you can think when you have low glucose, you think bacterial,
Bacterial, yeah.
viral. You also think cancer.
Mm.
See, this is going towards infection or cancers.
Cool, awesome. And then sometimes when you have elevated proteins, the first thing you think of is, are there cells? And here we can probably account for the elevated protein because of the white cell count. And they didn't do red cell count.
Yeah,
But we'll
they
get.
did a routine culture and gram staining. That's next.
Okay, cool. Cool.
So routine culture and gram staining of the CSF were negative. Results of the blood culture was normal. The diagnosis of scrub typhus was validated. Positive results on indirect immunofluorescence, serum antibodies for Orencia Tsutsugamushi. Cryptococcal antigen test and serological tests for hantavirus, EBV, CMV, leptospira, mycoplasma, Legionella were all negative.
I have a quick question.
So they ruled out all the viruses then.
Yeah, I have a quick question. As far as like, so it says the diagnosis of scrub typhus was validated by positive results. Like, how do you know to order that? Like, for example, I know for example, in like the pediatric world, you have like a respiratory viral panel, and it screens for like 15 different things. Like, how do you just like, oh, let me think of like, you know what I mean? Like, how do you know like, oh, I should think about scrub typhus? Does that make sense? Like, is there just like some random test like panel and it tests for like 15 plus things and that just kind of popped up? Is that a thing? Or, you know, like,
Yeah,
know.
so I asked a similar question when I was on general neurology service, because sometimes it seems, you know, we just click. And so one thing I've challenged myself to do is, okay, besides just getting the autoimmune or getting the meningitis encephalitis panel, really, really thinking through, do I think this patient is at risk for West Nile or cryptococcus or mycoplasma, right? Like, so sometimes it's you get, there's this encephalitis meningitis panel, you click it and it just runs through all these, different bugs.
I see.
So that's probably,
It's
so
the
let's see.
panel like that you order, like it's like you were saying, it's like a meningitis panel, and like something magical just kind of happens to it when it gets sent off, and then magically something grows or doesn't
Right.
grow.
Like if you
I
see
see.
routine is negative, right? So I'm guessing that's when they went for the next, whatever panel was there in the list, right?
Yeah, like the panel like tests for X amount of things, and then like whatever pops up. Like I guess like, because this looks like this is some sort of panel that tests for some like a bunch of like random weird stuff, kicky stuff or whatever, or viral stuff, because all these are like viral, some sort of like, but like I guess I'm just thinking like, it's not just in your head like, let me think about scrub typist, let me order scrub typist. You know, I just want to make sure. Okay.
it's not in my Maybe it's
Okay,
heavy, I don't know.
Because it's not
I
on.
would not be thinking of ordering serum antibodies for this.
Yeah, clarity was necessary.
I think what tends to happen at times is like you order the basics. What's most common? What's most what's endemic or in that area? What are the common bugs that tend to present? And then if you test those and those come back normal, sometimes we'll get additional CSF, and then we'll start ordering like specialty tests and be like, well, we've ruled out what's common. We don't know what else. Let's see if it could be some of these more rarer bugs.
Totally.
Done.
Yeah, totally.
Okay, so the diagram that we saw, we have a description. The eschar is taken on day 17. This is A. This is after day 28, which is B, which is almost like a healed scar here. And C is after initial symptoms. So this is the first one, I guess. Okay.
Oh, look, you guys, they got entire imaging of the spine. That's good.
Yeah.
Like we talked about, lower
So
motor weakness bilaterally can be due to a cervical process.
So brain MRI and whole spine MRI were performed without delay under suspicion of encephalitis, Guillain-Barré, or myelitis, but they revealed non-specific findings. There we go. However, 12-hour follow-up enhanced whole spine MRI scans demonstrated swelling of the spinal cord with a high signal intensity on T2 weighted images with poor enhancement between lower C spine and T5. You were right, Dr. Ighodaro.
Nice.
The lesion involved mainly the central gray matter, which is this one. Let me see if I can share the bigger one. Yeah. So this is the one. So this is an initial sagittal T2 weighted. Trying to read the description. Magnetic MRI scan of the lower C spine. Do you still see my screen?
Yes.
Okay. And upper T spine, which is A, shows no significant signal change or abnormal swelling in the T spine, which is correct. Yeah, this looks pretty smooth.
So let's talk about imaging, because this is also high yield and it gives you bonus points on rounds. And you guys know my philosophy with looking at imaging. So let's say your attending pulls this image. Oh, where'd it go?
Oh.
Let's say your attending pulls up those scans, because they'll do this. They've done this. They do it to me. I've seen it all the time. They'll pull, like you be in the big workroom, you're on rounds. They pull up the patient scans and they say, okay, student doctor so-and-so, read this scan. And you're sweating. You're like, oh, where do I start from? So I had an attending tell me this. Start from do it in a very systematic way because it'll give you time to think about what you think is going on. So you say for panel A, you tell me what scan is this? Is this MRI? Is this CT? Boom. We know this is MRI because it's highlighting a lot of tissue. If this was CT, you see a lot more bone, hyperdense regions of the vertebral bones. Yes. So we know that. It gives me time. Okay, this is an MRI. Now then you tell me what orientation is it? Is it axial? Is it sagittal? Is it coronal? So this is a side view. So we say this is the MRI. What is it of what? Is it the head, the spine, the chest, whatever. So this is an MRI spine with or without contrast. This one looks like without contrast, and over time you'll be able to pick up, with and without. So you tell me what imaging modality, you tell me what organ we're looking at, you tell me is it with or without contrast, and then you tell me the orientation. So this is the MRI spine of maybe cervical, maybe thoracic and lumbar.
Yeah, this looks thoracic and lumbar because we don't see anything beyond this.
Yeah, and how you can tell it might be cervical and thoracic. I'm not sure. Maybe, so you look at the size of the vertebra. So as you go down, the cervical tends to be smaller, thoracic is a little bit bigger, and lumbar is like huge, and sacral kind of tapers out. So I know it's not sacral. So it could be, I think this is.
Yeah, this looks like.
Is this lumbar? And then we can always check ourselves. Maybe I would say thoracic lumbar is my guess. And then is this T1 or T2? So I know it's T2 because T2, you see the CSF is white. CSF is white, it's T2, unless it's T2 flare and the CSF is dark. But here, CSF is white, so it's T2. So this is an MRI spine, sagittal, without contrast, T2 of the thoracic and cervical region. Boom. That gives you about a minute to think of, okay, as you're saying that, it gives you a minute to think about, okay, is there anything abnormal? Does that make sense to everybody?
Yeah, I like that systematic.
And you use that every time you look at the image. So, and it gives you bonus points. So let's say you don't even know the abnormality, but you say all that, they'd be like, rock star. And then they try to recruit you to neuroradiology. And they say, okay, I'm going into neurology. But that's how you shine on rounds when you're attending and pulls up an image and says, read it. Cool.
Okay, so this one is a T2, possibly thoracolumbar level. We see the full spine and CSF is white, but I don't see any abnormality here.
Yeah, I'm not seeing any.
Second one here. Let me go back and read the case report. So this is an initial sagittal T2 weighted MRI scan showing lower T spine and upper T spine.
So it's cervical and thoracic. Okay.
Shows no significant signal change or abnormal swelling in the spinal cord.
Nice.
After 12 hours follow-up, sagittal T2 weighted.
Oh wait, let's not read it. Let's look at. Can you pull up panel C? Let's test ourselves.
Okay, so this is the B.
Awesome. Okay. So who would like to read B and C? Well, it looks like B and C are the same modality. So who would like to read C? Systematic.
Again, possibly, since we know A, it's the same level as A, which is the cervical spine and thoracic. This is not T2 because CSF. Oh wait, CSF is white in C. But in T2, all the bony structures also appear hyperdense, right? Which is not the case.
Yeah. So what they did, so if you look at B, you see how they probably fat suppressed it in C to really highlight the CSF. So A and B are pretty much similar imaging. It's just that C has fat suppression, would be my guess.
Mhm.
Because you don't see like, like the subcutaneous back tissue is not highlighted in C like it is in A.
Yeah. So are these two same levels still?
Yeah, I think it's the same image, but I think one is further anterior than the other one because it's all sagittal. So you go from left to right. So I think B and C are not at the same like sagittal plane.
Okay.
And we can practice reading. There's a really good website that allows us to scroll through, and we could make that one of our study sessions where we just practice reading spine imaging.
Do you want me to pull up something now?
Oh, we can do it later. So C looks like it's going to be is this MRI or CT?
It's definitely
So
an
MRI.
Awesome, good. Is this T1 or T2?
T2.
Good, because CSF is white. Now CSF is
Yeah.
always going to be white, but for this purpose, CSF is white.
Mhm.
And T2. So T2, is this, what cut is this?
Sagittal.
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 Awesome. So MRI spine, T2 sagittal of the cervical thoracic region. Fantastic. So the CSF is supposed to be white, and then the spinal cord is supposed to be kind of this grayish region, very uniform throughout. But we see, as the arrows are pointing, is that there's some so you use the word hyperdense, hypodense for CTs, but in MRI you use hyperintense, hypointense. So in the spine we see some hyperintense regions, which are right, that are longitudinal in nature, and it looks like they're more than 3 segments. So I would say, this is an MRI sagittal spine without contrast, T2 in the cervical and thoracic region with some abnormalities, hyper intense regions along the spine. Oh, you say that, you think attendant would be like, you sure you don't want to do neuroradiology? You'll say, no, I'm sure. Look at my neurology, backpack. I have all my tools. I'm good, but thank you. Put that in my eval. That's what you say. And then you go on. Okay.
So
Very
there's a
good.
D now. Moving on to the D.
I think this is T2 flare is my guess.
Yeah,
this
that's
one.
what I was thinking too, because the arteries are hyper intense, right? In T2 flare, like those pop up.
So basically what happens in T2 flare is that the CSF is dark.
Mhm.
But in T2, so the difference between T1 and T2 is that in T1, the gray matter is dark and white matter is light. But in T2, it's opposite. You guys, am I right? I'm right, right?
Yes, you're correct. Yes.
If
I
I'm not,
trust you, not me.
oh,
I will pull it up.
Google 1 second. I want to make sure I'm telling
Yes,
everybody
I'm
right.
going to pull it up. Yes.
Okay.
T1 MRI. Here. So for T1, bone is a dark signal.
Oh, this-
CSF is bright.
No, this isn't T1. This is T2.
Oh, this is T2. Okay. let me
Yeah.
check.
Let's look at an image that has all 3 modalities. I think if you type in T1 versus scroll down. To your right, there's a really good one.
This one?
Awesome. Yeah.
Okay.
Oh, nice.
Oh, that's a good one.
So for
So in T1, okay, T1
This is T1 on the left.
is good. So how I remember is T1, it follows neuroanatomical like patterns. So gray matter is gray, white matter is white, and T1 is good for looking at anatomy. So that's how I remember. T1 follows neuroanatomy rules. So it's gonna, gray matter is gonna be darker than the white matter. That helps you with the anatomy. And then T2 is just the exact opposite.
Mm.
T2 CSF is bright, gray matter is gray, white is darker. So this is the T2.
So then now,
then-
so we have MRI brain, we have T1, T2. We talked about the differences. So now we have T2, you can break you can break down T2 into two sequences, T2, normal T2, and then T2 flare. And normal T2, the CSF is bright. In T2 flare, CSF is suppressed, it's dark, so that because then it brings out the abnormalities on T2 flare. So actually, oh, I could do whiteboard. Okay, let me see how I can do whiteboard on here. Because this, I'm all about like concept maps. That's how I learn things more efficiently. So let me see.
Are you sharing a screen?
I am trying to, let's see if I can annotate. Let's see if I can do a whiteboard. Can I do a whiteboard?
Oh, here, this is the one. In your share screen, it's there. This option is there. You see this?
Oh, awesome, cool. Do you guys see my drawings? Oh,
And not yet. Can you share it again?
share screen. Awesome. You guys see my whiteboard?
Yes.
Cool. So when I think of like, I'm just gonna type this. Brain MRI. So with brain MRI, I'm all about concept maps. We have T1, and then we have T2. So then you can take your arrow. Oh, where'd it go? Let me see. How do I draw? So then, so boom. So when you think brain MRI, you think two modalities, T1, T2. And then with T1, you can break T1 down into
Like flare.
T1 with contrast. And then without contrast. Those are the big differences, or the two types of imaging sequences you'll see on brain MRI for T1, with or without. And then for T2, that's when the flare comes in. No flare. And then flare. And that's how I remember everything. Oops. And then we know the difference between T1 and T2 is, gray, if this follows anatomy. And which is just going to be the opposite of the anatomy. And then there you have it. Does that make sense? Actually, this is MRI, brain, and spine. You can apply this to spine as well. So remember this basic concept, and then you can start adding on to this basic framework here. Because then, you come back, the more you learn, you can then, add more notes, be like, oh, with contrast, it's usually with gadolinium. And then without contrast is really good for, you can come back and add to this. This is really good for looking at anatomy. With contrast is really good for looking for like, enhancement, infection, tumors. T2, no flare. It's not really anything major, at least in neurology, but T2 flare is really good for looking at edema. And the really big thing is like vasogenic edema. So one of the strategy that I have learned when it comes to studying is, okay, if I learn something new, what is the basics and how can I break it down to its fundamentals and create some kind of chart so that when I look at it, I'm learning like 10 different high yield facts at once and not just, reading over and over and over and over again, So it's really taking a lot of information, digesting it and putting it into something that makes it easy for you to learn personally. What I learned best with is like creating concept maps and charts and tables because I'm a visual learner. So I look at this, I see it 10 times, I could draw it out. And then when they ask me on rounds, what is this image? I just work through this in my head. Does that make sense to everybody?
Mhm.
Yeah.
Cool. Awesome. We can get back to the case. Let me stop sharing.
Okay. So this one, so we saw B and C was the follow-up scans, sagittal T2 weighted fat saturation, which shows diffuse swelling of the spinal cord with intensely increased signal of the spinal cord, which is the arrows, these two.
But slightly below those two arrows, I'm also seeing a little bit increased signal intensity. I don't know if you agree
That
with
is this
me.
one, right? You're talking about this one.
That one, also those two arrows below, and also a little bit below that, there's
But
an
here it is B,
increase.
yeah,
Yeah, you agree?
here.
Yeah, I agree.
So the high signal intensity foci and relatively decreased volume of the spinal cord are due to artifacts. The arrowheads are the artifacts. Now on sagittal contrast enhanced T1 weighted fat saturation image, which is image D, which is this one, of the same section as in C, shows poor enhancement of the spinal cord. Okay, so these two are basically the same sections. Now we see the artifact as a poor enhancement of the spinal cord. The transverse T2 weighted MRI, which is this one, reveals gray matter hyperintensity. I'm not sure what to make sense of this now. Do you want to explain?
So for C or for D, I'm just saying. So it looks like D is T1 with contrast, and usually with infection, you see some kind of enhancement of that region, and sounds like we're not seeing that enhancement. So it's like, okay, why is, infections enhanced, inflammatory stuff enhanced, that's not enhancing. It kind of changes our differential. And then for E, it says gray matter hyperintensity.
That is this image.
Yeah, so it's abnormal. It's not supposed to be there, but it highlights that whatever's going on is only affecting the gray matter, which is the cell bodies and the tracts of the spinal cord. It's not affecting the white matter. Sorry, the white matter is all like the different tracts and highways. It's only affecting the cell bodies. So whatever's going on is only affecting the nuclei, and then that can help us with our differential. I think certain viruses and bacteria only affect the cell bodies, whereas others kind of affect the long tracts. So I think those imaging findings just help us more with what the differential is.
Okay, so fever, chills, myalgia disappeared completely after 2 days. On day 5, voiding difficulty improved, motor power, both extremities increased to grade 3/3. On day 7, follow-up MRI scans revealed dramatically decreased extent of increased signal intensity of the spinal cord with only subtle signal change remaining in the gray matter.
So whatever's going on in this guy is improving after being on
Yeah,
antibiotics. So that's good for him.
and steroids.
Oh, steroids.
Oh, did they say they gave steroids? I didn't see that.
I think they say it in the sentence afterwards,
Okay.
but maybe they gave it. When did they start? Oh,
On day 10,
oh.
they started the steroids. So day 7, he hasn't received, he only received doxycycline so far.
I thought
No,
coming all the way up.
yeah.
If you go up, I believe
here.
they mentioned steroids.
On day
but-
10, they say after 7 days of steroid pulse therapy by injection, the steroid intake method was changed to oral. So yeah, they did start on steroids. You're right. So now going to the figure 3A, which is this now, which is the decreased extent of increased signal intensity of the spinal cord with only subtle signal change remaining the gray matter. So now compared to the previous change, we only have subtle changes, which is in comparison over here. Now we only have this, like it's very subtle. Which is at a 1 week follow-up, T2 weighted fat saturation MRI of this lower C spine and upper T spine shows improved extent and degree of the spinal cord signal change.
So I guess my
Basically-
question is just what's responsible for like the hyper, like what are like causes of or intensity in like specific regions? Like what is that, because like, for example, like in the brain, when we think about like hyperdense regions, we're thinking like blood, or we're thinking like, so I'm just kind of wondering like, what does hyperintense regions mean for CNS or for spinal cord?
It
You
usually,
know,
it usually can mean like like a demyelinating, inflammatory, infectious, cancerous process.
okay.
So we have a couple of images. Do you want me to pull any of them? Yes.
Can you try typing in differential diagnosis for hyper intense spine lesions? Oh,
Okay.
fantastic.
Well, I think, you literally just nailed like almost every category there. Like you mentioned demyelating, you mentioned, I think the only thing that just wasn't touched upon is vascular, but yeah, like inflammatory, infectious,
So we have
tumor.
demyelinating, vascular, tumor, inflammatory, infection.
I see.
Nice.
Okay, cool.
Let's see here. Let's see. Can any of these cause specifically, because I think, can any of these on here cause specifically gray matter lesions only? Not that I see. Okay, cool.
Yeah. So he's actually improved by day 7. Now by day 10, they moved the steroid to oral, and motor power has actually improved to grade 4 now. On day 16, patient was able to void voluntarily. On day 20, he was transferred to a rehabilitation department of our hospital, and day 40, he was discharged. Wow. This almost seems like MS.
Or even Guillain-Barré,
Yeah,
because that's
true.
also an acute, process. But I totally hear you on that.
Yeah.
Yeah,
This MS
Guillain-Barré could be,
guys-
but because we have upper motor lesion, I guess that's what eliminated Guillain-Barré diagnosis, right?
It's
No, it's
true,
still-
because it would have,
Still
It's-
could be.
Yeah, still could be, because Guillain-Barré is an ascending polyradicular neuropathy.
Mhm.
So it's it ascends it can, affect, it tends to affect the peripheral nerves first, but then it ascends and affects, other
Yeah,
nerves.
but
It
isn't it
also,
continuous? Isn't it continuous? Because
Yeah.
here we have discontinuity from, in
that's
the
true.
lesion. That's why.
But one could argue that the reason why it stopped is because he was treated. He got the steroids and he got the but with Guillain-Barré, usually it's IVIG, steroids, and Plex. So maybe
Yeah.
steroids prevented it from continuing to ascend. Someone mentioned
MS.
Someone mentioned MS. So MS, it's unlikely in this case because usually MS presents with like optic neuritis, visual field findings, visual field deficits. And although it is on the differential, I think it's very low. And the fact that, so he presented, I mean, you can present with, like a myelopathy type picture, but he presented with fevers, chills right after a bug bite. So if this was a board question and they said of the following, which is most likely etiology, and they have MS on there, I wouldn't circle MS per se. I think there's more things higher up on a differential that explain his symptoms. But I just thought I would, throw that out there.
Yeah. Also, he has CSF findings of decreased glucose, increased protein. MS also wouldn't explain that decreased glucose. Transverse myelitis is also possible. Transverse myelitis.
Usually with transverse myelitis, you have a sensory level. It's not
correct. Yeah, that's what I'm
ascending, right, Seema?
Yeah. Yeah, correct.
Boom, all of a sudden something hits the spinal cord and the acute nature, usually the symptoms are max, after the first insult, and it's not a acute progressive disease.
Yeah. Okay, so neurological examination on an outpatient follow-up at 3 months revealed near complete resolution of motor power of the lower extremities, grade 4+ by 4+. And follow-up MRI showed complete resolution of the increased signal in the spinal cord, which is 3B, which is, this one. So this is again T2 weighted image, correct? It's a T2 weighted image, C spine, thoracic spine. Yeah, we can see the bulge.
Yep, very good.
Then Escher was photographed again on the 28th day after initial symptoms, which is figure 1B, which is going back here. This is what it looked like on the 28th day now. And the crust disappeared completely, leaving only a whitish scar-like macule indicating fibrosis. Dermatoscopy revealed a healed lesion with the red-brown pigmentation of the surrounding erythema, which is figure 1C, which is this C, this one.
Well, good thing this is a neurological process that is acute and, it's an acute process that was resolved because a lot of times, unfortunately, neuro, that's not the case. So.
Yeah, so the discussion is scrub typhus can be diagnosed patient history and clinical features as well as serologic tests. And Escher at the wound site is the single most useful diagnostic clue. In our case, we were able to diagnose the scrub typhus because of the presence of an eschar on the neck, a history of outdoor activity, and a significant increase in, I forgot what is the O, Su-Gamushi serum antibody titer with typical clinical symptoms of fever and malaise. CNS involvement in scrub typhus is not uncommon. It is due to O-Su Gaucher infection can be caused by direct invasion of the CNS by this organism and has been demonstrated by a PCR of CSF, or by microinfarcts in the brain due to unique propensity of O-Sutsu Gaucher to infect vascular endothelial cells. So jumping ahead, they have discovered the CSF PCR analysis in 24% of the patients. Autopsy showed the CNS involvement in almost all affected patients. Relatively common reported conditions reflecting CNS involvement are encephalitis and meningoencephalitis. However,
May I
at
just-
the time of our
Oh.
admission, yeah, go ahead.
Oh, sorry. I was gonna say, may I just add something? This is a great case, unique, very unique. May I just add that, like, this is where one thing I really love about neuro is, like, neurologists are very detail oriented about HPI, like, tell me everything, you
Yes.
know, and that is one thing that, like, is striking about neurology, you know, really diving into the HPI. And so, like, you know, sometimes patients don't think, oh, like, they don't, something like hiking wouldn't be something to tell a doctor, like, oh, I went hiking like last month or a couple weeks ago. Like, that's not something that the average human, even physician, if they were in the patient's shoes, would be like, oh yeah, I just went hiking and now I'm not feeling well. Like, the association wouldn't be there, and therefore someone wouldn't just necessarily, you know, give that information willingly all the time. So this happened to be a case where it was like, you know, that was investigated. So yeah, this is a really cool case.
Yeah, so they talk about, in our case, initial spinal MRI scans revealed non-specific findings for the spinal cord. It is generally accepted that MRI performed immediately in patients with the ATM may be normal, but will demonstrate signal change over time. So
What does
12
ATM stand for? Is that acute transverse myelitis?
Yeah, this was a case on acute transverse myelitis. When
Oh,
I
nice.
looked at PubMed. It says successfully managed acute transverse myelitis related to
Oh,
streptitis and serial.
Well, I guess it can be ascending. Never mind.
Yeah, I actually added that link in the chat. This was a rare case of acute transverse myelitis due to scrub typhus. So the abstract is CNS involvement manifesting as meningitis or meningoencephalitis is known as a complication of scrub typhus. But very few spinal cord lesions such as acute ATM have been reported in association with this disease. So this is a rare.
Nice. This is a really good case.
So if you want to know, the other symptoms of scrub typhus are usually mild, and clinical course is self-limited with spontaneous recovery after a few days. However, some cases are more severe and protracted and may involve lung, heart, liver, spleen, kidney, GI tract, and CNS. So CNS can manifest as meningitis or meningoencephalitis. Other neurological manifestation includes cerebral infarction and brain hemorrhage. Although there are no reports of brain lesions and meningitis in patients with scrub typhus, reports of spinal cord involvement, such as ATM associated with scrub typhus, are extremely rare. So going more, it's a focal inflammatory disorder of the spinal cord characterized by acute or subacute motor, sensory, and autonomic dysfunction. Preceding are non-specific symptoms like fever, nausea, muscle pain, possibly indicating viral infection are common and usually associated with MS, systemic mixed connective tissue disorders, direct infection of the spinal cord, such as mycoplasma or herpes. I think this is what you were asking, right, Laura? Is there a panel that would be ordered for the spinal cord when we know when we have these symptoms?
Yeah.
Vascular causes such as infarct or vascular malformation, but can also appear without established etiology. There have been no previous reports with serial image findings or reports of resolution of ATM associated with scrub typhus. Wow, this one actually healed pretty quickly within 10 days, right? So going further, if you want to know about the other GBS and things, so I'm just going to go ahead and read. So 12-hour follow-up, we read that. The gray matter of the spinal cord was predominantly involved here, and this is in general accordance with the previous report of scrub typhus associated spinal cord involvement. This may be because metabolic demand of the cell bodies in the spinal gray matter is very high, making the gray matter site most sensitive to ischemia. Interesting. In majority of cases, whether acute myelopathy is inflammatory is not self-evident in both clinical symptoms and imaging. Therefore, when a patient with myelopathy is systemically ill with fever and meningismus, prompt investigation of the causative agent is needed for appropriate management. I guess this explains it, why we need to order further to do more workup. For this reason, awareness of causative infectious agent is of paramount importance. Now coming to Guillain-Barré, it's an illness characterized by arc-flexic ascending paralysis with minimal sensory involvement. GBS is usually preceded by infection or other immune stimulation that induces an aberrant autoimmune response, targeting peripheral nerves and their spinal roots. GBS has been previously reported as a complication of scrub typhus. It is associated with image findings include thickening of conus medullaris, cauda equina, with strong enhancement of post-enhanced MRI scans, which were not observed in our case. Let me see if I can find a picture.
So with GBS, like what bladder problems, or would you have bladder problems? Because you do have the ascending paralysis, and it is a peripheral nervous system like pathology. So would you have like
it depends on what state, or the acuity of the infection. You can have either urinary retention or urinary incontinence. You can have bowel, incontinence or bowel constipation. So you can have both.
I was thinking that, but probably less likely on like the urge incontinence or like the spasms, like as if it was like some sort of autonomic dysfunction or like some sort of upper motor neuron. That would be a little bit like you would have to go a little higher up, right?
Or GBS?
That's a great I am not sure.
Let's
but
see.
Let's look.
Okay, here I have a picture. So first is hands and feet begin to have a tingling sensation. Number 2 is muscle weakness, making it difficult to climb stairs or walk. And third is the respiratory symptoms. Let's see if I can find more pictures. Okay, this is just they're talking about the altered mental status. Okay, so this is the initial symptoms associated with GBS. But this has other stuff like CMV, Campylobacter jejuni.
Oh, if you scroll down, so it looks like muscle weakness, altered mental status, diarrhea, vomiting. numbness, paralysis.
Yeah.
And it looks like these are just some of the bugs, because you know you can have mycoplasma, Campylobacter is like the board question that they always ask. Diarrhea. Interesting. Awesome, awesome. Great job, great case, great work.
So yeah, that's it.
Cool, cool, cool. So, let's see. Do you guys want to go over imaging for MRI?
Yeah, let's do that.
I could definitely use some work in that department. So
Cool. Okay, let me find that website that I love using. I love going to it. And I'll send you guys this link in the text as well. And if anybody else wants to lead a case, just let me know. We're going to be doing emergency neurology for a couple, maybe another month, and then move on to a different sector.
ooh, I love emergency neuro.
It's because you're biased, you ICU neuro life.
I love it. I'm here for it. Let's go. Hypertensive stuff. Subarachnoids. Come on.
I've seen a couple of subarachs and intraparenchymal hemorrhage. That was pretty scary. Do you guys see my screen?
I do.
So I love this website. It is free, and it's what I use to learn not only my anatomy, but I learned my anatomy alongside learning my neuro imaging. So let's.
This is golden.
Yeah.
Oh my goodness.
It is so good. Because I'm all, if you guys haven't picked up, it's all about efficiency. There's so much to learn, right? So how can we be efficient in learning the material? So if there's a website where I learn both anatomy and imaging at the same time, well, that's better than, trying to learn it one by one. So this is a really good website. And another thing I have learned along the way is just because you read it doesn't mean you know it. Like you want to read something and you don't want to have to read again. So as soon as you read something, quiz yourself, or the next day be like, okay, what did I read? Try and quiz yourself, try and write down, okay, here's all things I learned. Go back to whatever you read it, see what you missed. And if you do that, they call it like interactive or learning, it sticks better versus just reading passively. That's just one of my tips. So this is such a great website because it gets to that, well, can I quiz myself? So, for example, you can toggle on and off different anatomies. You can they have this practice where you can kind of quiz yourself on the, different anatomy regions. So I really like it. What I do is when I have a patient image, I pull this up alongside the patient image and then try and make sure that I understand important landmarks. And I understand, what the radiology is saying or mentioning. So that's my study tip, one of my study tips. So let's do some. Let me pull up
That
some.
was scary.
No, we just break it down.
Is this the neurophobia that people are talking about? This must be it right here.
Yeah. But that's, that's why I do these groups. It's like, you don't have to be afraid of neurology. Neurology is beautiful. You just got to break it down into its, into its smallest units. And then once you know the basics, like this is the spine. Oops, what are the basics? How many cervical regions? How many thoracic? How many lumbar? And then once you know the basics, you add on little by little by little, and then eventually you'll be able to know all of this stuff. I don't know all this stuff, but that's okay. So I add on little by little by little. Okay, so let's do this 3D. Oh, well, let me do a 3D. You need a 3D, you have to pay for it, but that's okay. We can still do, let's do what we just got done learning, and I'm still trying to toggle this. I want to turn off some of this stuff. So look, I can even turn off stuff. So look, it's not so scary. I turned off some stuff. Okay, so first thing first, what are we looking at?
C-spine.
Fantastic. So we have a C-spine, sagittal, T1, no contrast. Boom. That's the basics. Very good. So then what I could do is add on the bones. Like, which one is the vertebra? Actually, I want to count it. The numbering. That's what's most important. So you come here and, you have this pulled up alongside your patient's image pulled up, and then you just, compare. Okay, this is what's normal. I look at my patient. Is this normal? Is this not? What's going on here? But you can use this to kind of help you orient your anatomy. So how many cervical vertebrae do we have in the human body?
8.
Vertebra,
Um,
bones.
oh, that's 7.
Good. How many cervical nerve roots do we have?
8. That is
Good.
8.
And another high yield, they ask this more so on neurology boards, is what's the difference between the spinal nerves that come out of the cervical region versus the thoracic and lumbar? The difference is in the cervical region, cervical root 1 through 8 will exit out of the spinal cord on top of the vertebral body, versus when you get down to the thoracic and the lumbar, T1 comes out at the bottom. A T1 spinal nerve root will come out the bottom of the T1 vertebral column. So that's more so for residents and fellows. Okay, cool. So here's what the vertebrals look like. You have one that's pretty much right underneath the brainstem and the cerebellum. You have one, sometimes 1 and 2 are fused in some people. So here it's kind of hard to see 1, but just know 1 and 2 are kind of fused. Then you have your disc in between, and then C3, C4, 5, 6, and then 7. So cool. So now what else so now that you have the vertebrals numbered, I don't care about the ribs. I really care about, let's see, this doesn't highlight the spinal nerves. That's okay. This tells us the meninges. Okay, another thing is the spinal cord. So the yellow part is letting us know where the spinal cord is. And then you have spinal cord, segments 1 through. The spinal cord is really nice. What you want to basically look at when you're looking at sagittal view of MRIs is to make sure that the vertebral bodies or the bones are not causing any impingement or stenosis of the spinal cord. So you see here how it's nice and open, and there's no discs that are pushing in, bulging on the spinal cord. It's fairly patent. That's pretty much all we need to look at, when we're looking at imaging. There's no gross, huge tumor, impinging on the spinal cord. It's nice, it's pretty, it runs down. That's the big things that you're looking for here. Let's see, but let us kind of run through it. So any questions with that? Oh, let's look at T2. Let's go to T2. So I want to remove all this. So who wants to tell me what image this going rounds? What are we looking at?
CSF is white here. So
Yeah.
this is T2.
Yep. Good. Fantastic. We're looking at a T2 sagittal cervical spine image. That's fantastic. And here, this is really good for looking at, is there any impingement? Because you'll know if that there's impingement or if the discs are bulging, you'll see a really dark space.
Yeah, it looks pretty clean to me.
Yeah, if there was disc, this would be like pushing a lot further, and you would see kind of something like this. You know what I mean?
Mhm.
But we don't see that. So this is nice, it's flushed. There's nothing pushing on the nerve. The nerve is very grayish throughout for the most part. No areas of hyper intensity. It's just very clean and beautiful. And then we have what vertebra is this?
That's
C1,
C1, C2.
Yeah, exactly. C1, C2. And you see here how this is probably the intervertebral disc. It's probably just a little bit, it's probably fused.
Mm-hmm.
Awesome. I'm trying to see what else is important. And sometimes I used to think that, oh, what's this white space going on? What's going on here? And sometimes the intervertebral disc can be hyper intense, but it's just a normal variant. And sometimes the bone, sometimes you see how you have this white spot here and you have the white spot here.
Mhm.
That's normal.
Hmm.
You know, sometimes. So don't let that be a thing you focus on when you look at images.
When
And
you
then,
see osteopenia sort of, or in like the vertebra, like is it like airy kind of like black, like kind of?
you know, that's a good question, but if you're looking at osteopenia, you usually want to get like a DEX scan to really assess bone
You're
density.
right.
Yeah,
Yeah.
MRI,
Yeah.
I wouldn't diagnose like osteoporosis or osteopenia on MRI because MRI is not meant for bones. It's meant for like soft tissue.
Soft tissue and yeah.
Cool. Okay, so that's pretty good. And then when you do sagittal, you just kind of, you know, I always just try and look for the mid region, make sure it looks flush and clean. I could see the fluid all the way up. Where's my tape? I see the fluid go all the way from superior all the way to down. There's nothing obstructing the fluid.
Mm-hmm.
That's pretty much all I'm looking for on T2. Now T2 flare, let me get that pulled up for us. Oh, what is this? T2, huh? Maybe they don't have T2 flare. That's okay. I don't think they have T2. Oh, this was, no. Okay. They don't have the flare, they just have the weighted sequence. So yeah, so I think when you're looking at spines, just focus on sagittal first, and then once you know sagittal well, then you can go into like the transverse and the coronas and whatever. So another thing do they have T2, T1? Oh, they don't have T1 with contrast, but that's okay. Oh, it would have been good if they had T1 with contrast, but they don't. Let me just make sure.
When would you consider it in contrast?
Infection, tumor, really to assess spinal pathology. So I would always, like, if I'm getting the spine imaging, MRI, I'm always probably going to get MRI with contrast of the spine at least, because I'm probably trying to rule out infectious, demyelinating, inflammatory etiologies. Trying to see if they have sagittal. So there's a lot of great free stuff online. So one of my colleagues shared this with me.
Yeah, this is gold. Oh my goodness.
Trying to see if they have T2. Okay, they don't have T2 or T1 contrast, but that's okay. So yeah, so that's kind of spinal imaging basics in a nutshell. Any questions?
Can you go over the transverse section?
Sure. Let me transverse. Let's do trans. Okay, so, when I'm looking at these imaging, I always like to orient myself, this is the front, this is the back, because we see the cerebellum, we see that midbrain. No, that's medulla. So it looks like this is at the level of the cervical spinal cord. And let me get some arrows. And then we can number ourselves. So I first look for the fluid. Fluid is white, so that means whatever the dark space is inside has to be the spinal cord. And then outside of it, you see the vertebral bodies, and then posterior to it, you see like the transverse, bony processes and things like that. And then what you're really looking for on the transverse section is looking for areas of impingement of the spinal roots. So let me find where we can label the spinal roots.
They're right there, spinal roots. Yeah.
Awesome. So here you see the spinal cord, and then coming off the spinal cord, you can start to have your cervical roots, then thoracic roots, then lumbar roots. And what happens as we get older and people present with like back pain or radicular pain or myelopathy, one of the most common causes of lower back or of spinal cord stenosis in elderly individuals is going to be due to bony type abnormalities. And what I'm pretty much looking for when I order like an MRI is to see are any of these bony abnormalities causing the patient's, arm weakness, arm pain, or leg weakness or leg pain that comes on chronically. So let me get to a good level. So we're So here's the bone, that's C2. Here is the bony regions. I don't know all the names of the bones, but the transverse processes and the other part, what is that called?
Bony projections.
Huh?
Bony projections, right?
Oh, okay. Let me see if I can, will it label it for me? Okay, there you go.
Spinous process, like spinous process.
We have the vertebra. Oh, yep, good call. Spinous process, and then we have the interventricular foramen. So those are all the different parts of the bones. And then as we scroll down, you want to look and make sure, especially in this region. In this region here, you just want to make sure that it's patent. And that usually what tends to happen sometimes is that this intravertebral foramen will start to degenerate and then impinge on the spinal nerve root as it comes out of the spinal cord, leading to myelopathy type issues. I'm going to get rid of the bone. So you just keep scrolling down, and you see how all these spinal nerves are coming out. And this just really takes practice in looking and reading and making sure that there's no impingement of the spinal nerves. And also sometimes if you have like overt spinal cord stenosis, you see how this is nice and round? Sometimes the diameter will be a lot smaller, or it'd be like asymmetric or be more oval in shape. And then that can indicate some kind of impingement coming from the bony regions surrounding it, or a mass lesion or something else. But you're just really looking for, is this flush? Is it nice? Is it circular? Is all the white space there? And are the nerves, the spinal nerves coming out, are they patent without any impingement from the bones? And so the more you look at normal, the more you'll be able to help and like interpret your own scans quickly. Now, I always run everything by the neuroradiologist, but sometimes, you know, in neurology, we're trained at, we look at our own scans first because we know the patient, we know where the symptoms localize. Then we go talk to neuroradiology about, hey, this is where the symptoms are. They localize to this region. This is what I saw. This is, what do you think? And that's kind of how we do it in the emergency setting. Now, in the outpatient setting, you know, you look at it myself and then see what the radiologist reports. And then if I have questions, I can at least in my institution, I can always call them and say, hey, this is what I see. This is what the, you know, patient's complaining of. You know, am I missing anything or what? So
yeah, does it correlate to the imaging?
right. But yeah, this is such a great website. Did I put this in the chat?
You did. Thank you so much.
This is such a great website. This is what I would use to learn what normal is. And then over time, you'll start to pick up on what abnormal is, especially if you're going into neurology. Cool. Any questions or any topics or anything else you guys want to chat about briefly from a vertebral? Oh, we could do some rapid fire questions based upon our study groups or previous sessions and the group chats. So we talked about cervical has 7 vertebra and has 8 spinal nerve roots. What about thoracic, lumbar, and sacral?
Is it 12 for thoracic vertebrae?
Mm-hmm.
And then 12 spinal roots
Lumbar is 6.
for thoracic.
Lumbar 6? Are you sure?
Let me check. 6 is
5 lumbar. So like as far as vertebrae, so 7 cervical, 12 thoracic, 5 lumbar, and then what is it? 4 sacral? No, 5.
Yeah, so
Ooh.
it's 8 spinal for the spinal nerves, 8, 12, 5, 5.